And hello, everyone online. Thank you for coming. I'm Jimmy Stutes. I'm co-leader of Cancer Prevention and Control. I'm with my colleague, Stacy Fisher. And we are very happy to be presenting this next seminar series with Dr. Gina Kruse. Just wanted to see if anybody has any updates or anything to report. I don't think I have any major announcements, anything going on. Okay, getting a lot of blanks there, so we can go ahead and move on to the introduction. Dr. Gina Kruse joined us just this past summer or so, and we're very happy to have her. She is a native of Colorado, so she can actually have one of those bumper stickers called native on her vehicles. Not sure if she does or not, but she joined us from Massachusetts General Hospital, where she was working as an assistant professor and associate professor for the last several years. She joined us as an associate professor in the Division of General Internal Medicine, and she's a practicing physician, in addition to someone who has significant expertise in tobacco-related research, which is her connection to the Cancer Prevention Control Program.
Recovery.
She initially got her undergraduate degree in animal sciences from the Iowa State University in Ames, Iowa. I always like to draw out the Iowa connections because they're so meaningful to me. And but she also completed a master's degree in health sciences at Texas Tech before getting her medical degree at Baylor. And she continued a significant amount of her training at Massachusetts General Hospital, and then as a faculty member there. And so we are really excited to have Dr. Kruse here because of her expertise in tobacco control and really leading a lot of the tobacco control efforts across campus clinically these days, and trying to rejuvenate our tobacco portfolio following the retirement of Dr. Levinson. And so really excited to have her here, as well as her expertise in implementation science. So Dr. Kruse, thank you.
Thank you. I was actually born in Nebraska. So thicker, and I have an affection for the Cornhuskers thrown in there too. So it's an interesting family dynamics. So I'm so glad to get the chance to talk to everybody and tell you a little bit about my work. We're gonna mostly focus on some of the work that I've done leading up and focused on tobacco cessation treatment in clinical settings, with some of the stuff that I think is kind of cool and innovative and some exciting places to go and research. Kind of focus on research and not so much on the clinical services, although sometimes it would be lovely to talk about innovation and what we're doing there. So let's see, I just have a disclosure slide. I have a husband who started some mobile health companies. I'm going to talk about mobile health today. So his stuff is up there, and then my funders, some of the grants and the funders of some of the work I'm going to talk about today. I was going to try and cover three things. Just start off with a little level setting, the state of tobacco cessation treatment. I'm not going to spend that long on that, just sort of remind us like what we have in our arsenal right now and what's going on with connecting people with that treatment. And then I wanted to talk about the two kind of innovations that I think are especially interesting right now are, one, adaptation, how we take this menu of things that we have and make it fit the needs of different contexts, particularly in a couple of different limited resource settings. And then I want to talk about adaptive treatment models, which is one thing that I think is especially cool in tobacco cessation treatment, something that's been used in a lot of other chronic disease, and we just don't do it in tobacco. But I think we should, and I'll tell you a little bit about some of the thinking and what little has been done in that space, and maybe kind of highlight some of the Okay, so start off with the state of tobacco cessation. When you're a tobacco cessation researcher, your impact statement is not that hard in grants, because you get to start every grant with it's the leading preventable cause of death. Unfortunately, hopefully someday that will change. It's responsible for at least 480,000 deaths in the US each year, and I say at least because people who have been, that's 480,000 deaths based on the stuff that we have proven is caused by tobacco, but there's probably other things that just haven't yet met that metric of evidence. Globally, it's not just a US problem, it's a global problem responsible for about 7 million deaths per year. And while it's never viewed as a public health emergency, to put it in the context of our recent public health emergency in 2020, COVID cost us 385,000 US lives, and tobacco does more than that year after year after year. Currently, tobacco use in the US is, depending on which survey you look at, the first data is 22% of Americans used tobacco in the past 30 days. That's about 61 million people. That's based on the National Survey of Drug Use for Health and all forms of tobacco, so including electronic delivery products and oral products. The National Health Interview Survey tells us that 11.5% of US adults, this is the hot off the presses data, reported current smoking. About 28 million people are current smokers in the US. And of those current smokers, a third to a half are going to die of their tobacco-related disease, costing about 10 years of life on average. What are the causes of death from tobacco? You all know this. The big three are lung cancer, ischemic heart disease, and COPD. Lung cancer and COPD, tobacco causes 80 to 90% of those deaths from those causes in the US. And heart disease is a substantial proportion as well. There's also lots of other things that have met the burden of evidence saying tobacco causes things like diabetes, peptic ulcer disease, lots of other cancers like pancreatic and head and neck cancer, just to name a few. So with that public health issue, we do have quite a few things we can do for people. We've had a menu of treatments, behavioral and pharmacologic, that we've had for several years now, and lots of thought and writing on treatment models to get those treatments into people's hands. Some people have heard of the 5 A's. I like to talk about the Ask, Advise, Connect model. It's slightly abbreviated, easy to remember. Some people, you don't have to remember all 5 A's, you just have to ask, advise, and connect. And what that looks like in practice is everybody that interfaces with their healthcare system gets asked about tobacco use. Given the diversity of products and the changing products, it's nice to ask, do you ever use more smoke or tobacco product, as well as exploring vaping. There's the questions and screening items that we have for vaping are newer and not as well established for how you identify people that use those products or that identify themselves as using tobacco or nicotine products. But an example, some people have started to use stuff like the Craft N, which asks on how many days in the past 12 months have you used a vaping device containing nicotine, tobacco, or any tobacco products. So ask everyone who comes in and interacts with the system, and also ask about history and pattern, because that gives us some useful information as we think about how to help them quit. There's a robust, long-standing history of asking about nicotine dependence for people who smoke conventional cigarettes, how many cigarettes per day, and when you smoke your first cigarette gives us a good estimate of your level of nicotine dependence and how much support you're going to need to quit. We know less about people who use the other forms or use multiple forms. So we're still sort of learning about how we ask and explore that, but definitely if you have somebody who's using multiple products, you can ask about issues about how nicotine dependence or withdrawal is affecting their day-to-day. Things like there's something called a hooked on nicotine checklist, where it asks about cravings and concentration and all these things, all these effects of withdrawing from nicotine multiple times a day. For everybody that reports tobacco use, give clear advice to stop. With easy stuff, simple stuff like stopping smoking is the most important action you can take for your health, which is a pretty unequivocal and clear statement. And also focus on the benefits of cessation. It's never too late to quit. We know from epidemiologic mortality data that even if you quit over 65, on average, you gain 3 years of life. Statins don't do that over 65, only tobacco does. So it's never too late to quit. It's important for your health. And for everybody, even those who don't report tobacco use, encourage a smoke-free home or car, because we know people looked at NHANES data in 2018, they looked at cotinine levels where you can actually see environmental tobacco exposure, secondhand smoke exposure, as well as current tobacco use. And that tells us that about 20% of US non-smoking adults were exposed to secondhand smoke based on the biochemical levels in NHANES. So I advise everybody to adopt a smoke-free home and car. And then comes the connected treatment. So we've identified folks who are using tobacco, we've offered clear advice. What can we offer them to help them quit? We have two things. We have a bunch of behavioral stuff and we have a bunch of medications. And those haven't really changed that much in 15 years. Our US Public Health Service guidelines are from 2008, because we haven't had another medication on the market since then. The Chantix studies came out in 2006, and that was about our last one. So what we have in our menu is we have prescription medications of varenicline and bupropion. We have several forms of NRT. I like a first-line recommendation of varenicline or combination NRT. I'll show you why in a minute. But we also, for folks who can't take those or who need more help, we have other agents like bupropion and single agent. And if people need more help than just one agent, combining across classes has a growing number of trials supporting it. And for behavioral support, we also have an array, a menu of things. We have local tobacco treatment services that can offer in-person and telephone counseling. There's the Quit Line in all 50 states, and then there's also digital support like Smoke-Free. This is too many numbers to absorb, but the color coding is meant to sort of highlight and inform why I recommend varenicline or dual NRT as a first line. So one, varenicline is the most effective single agent pharmacotherapy that we have. It works a little bit better than everything else that we have on our list. And has had lots of trials demonstrating its safety and efficacy in lots of different populations. When you add a short-acting NRT like gum or lozenge or an inhaler to a patch, which is a long steady dose, you get something that's almost as effective because it gives you a little 25% boost on top of what you get from just a single agent. So either of those are really good first options. The one challenge to the short and long acting form is it's a little harder to do because you have the patch every day, but you also have this ad lib use, which is complicated. So those two are there. And then also like to highlight the purple here is this sort of growing body of evidence that you can combine across classes for people that one agent isn't enough. And in particular, if you believe, this was based on a review of reviews. It's based on some Cochrane reviews largely. And the varenicline and bupropion even is classified as moderate level evidence now that that's the thing that you can combine safely and for people that need more than just one. The behavioral treatment list doesn't look any smaller. It's also a lot to absorb, but just to highlight, we have healthcare provider delivered brief advice, telephone advice, group counseling, text messaging, all with high to moderate levels of evidence. We have internet-based interventions that's like smokefree.gov that also have moderate evidence, financial incentives, like we particularly use this in expectant moms, contingency management, financial incentives to quit. The one thing that hasn't met the body of evidence yet is apps, even though there's tons of them out there. This is based on a review there was finally one trial of an app that showed long-term efficacy. It's an acceptance commitment therapy app. So this is probably out of date because it doesn't include that ACT trial. But so far, that's it. We don't have that much in the apps that we can say like there is solid evidence that this is going to help you, although it's probably coming. Okay, and then to summarize all that, which is like this is what we have. Oh, sorry, one more slide, and then to summarize all that. So the other thing is that we know that putting those two together works better than either alone. So to the effectiveness of the pharmacotherapy or the effectiveness of the behavioral therapy, if you add the behavioral to the pharmacotherapy, you get even more effect. And so that's really the most comprehensive stuff we have in our menu of treatments right now. Here's the summary slide. Effective treatment exists. Behavioral pharmacotherapy combination is better. More is better, but even brief advice works. So like on some of those behavioral, some of that is brief physician advice, which is like 2 minutes. Or a pamphlet, a self-help pamphlet has demonstrated that long-term efficacy. It's not the strongest thing we have, but it works. But again, just to highlight, this is last updated in 2008. So there's room for innovation here. So that we have this public health problem, we have this array of things that we can do for it. So how are we doing getting that to people? So I was digging through some data, trying to find some Colorado specific numbers. I know there's a bunch in the Cancer Center collected, but I found this, found some data from the tobacco use supplement to the community population survey from 2018 to 2019. Overall in the US, vast majority of people who smoke are interested in quitting. This is smoking specific, not other forms of tobacco. Majority have tried to quit, a little over half. That's pretty standard and it's been pretty stable for a long time. About half people who are smoking are trying to quit. Overall in the US, 71.8% of people said that they were advised by a healthcare provider to quit, and about a third used one of those evidence-based treatments, one or more. If you look at Coloradans who smoke want to quit, 83.6%. Many of them try to quit, a little over half. But we're not doing quite as good, at least according to the tobacco use supplement, in advising to quit and connecting people with treatment. So much that that advice to quit number, that 63% of Coloradans in this survey said that they were advised to quit by a healthcare provider, is actually last out of the 50 states. Now there's a couple others that are down there, but I didn't expect that, so I was surprised by that. So we have some good work to do. And then cessation aids too. We're in the bottom half, not the bottom quartile on that one at 29.8% people. So there's a clear treatment gap here. And that we have this stuff that works, and not everybody's using it. And that could be driven by us not having an effective treatment model to connect people with that. Could be driven by we don't have treatments that people are particularly interested in using it. And it's hard to tease this out in some of these national surveys, but we'll talk a little bit about some of these. And then just to set myself up for some of what I'm going to be talking about, I studied tobacco domestically and globally. So some of these patterns look similar in global settings. If you look at the Global Adult Tobacco Survey, which is a comprehensive international survey, it's 31 countries that collect this data over various time points. So it's sort of a long range sample. The median number of people who smoke who made a past year quit attempt is 39.6. And then the range there is like the lowest percent per country and the highest. So one country had 54.7 people in this 31 had 54.7 people making a past year quit attempt. The vast majority do it without assistance. So it doesn't look so dissimilar. 74%, median 74% people do it without assistance. With that in mind, so we have a clear public health problem. We have some treatments. We have a treatment gap. Some of my work has focused on how we try to connect people with some of the treatments that we have through trying to make it a better fit, either for the care system or the end user. And so we're going to talk about a couple of examples of adapting some of those evidence-based treatments to meet specific contexts, to try and make them more appropriate or a better fit. We're going to look at a couple of limited resource settings. The first one is community health centers in Massachusetts. So we had this idea that primary care system, where you know who is a smoker, because we do a pretty good job asking and documenting about smoking. You can outreach people and offer them assistance, because we're not getting enough treatment out there when we're just waiting for people to come in and say they're ready to quit and get treatment. So can we outreach people and nudge them and give them an easy step to take towards quitting? Because most of them want to quit, even if they're not coming in and asking for treatment. So can we do outreach? And can we thought it would make sense to do that by text message. It's cheap, it's scalable. Nearly everybody has a text messaging capable phone now. And there's evidence that it works to help people quit smoking. So we had our adaptation task was to say, let's take some of the programs that have demonstrated efficacy, like many of them are very similar. We started with smoke-free text, which is NCI's version. And let's adapt it to a primary care setting. So people can see that this is content that's supported or coming from their healthcare provider, because we know that source matters in messaging effectiveness. And making sure that it leverages the resources and things that are available to people here in a way that a national texting program can't, with the idea that it might make it more effective and more immediately relevant and actionable. We linked this in with some activities to add a couple of other novel elements that weren't adapted but added, which is content for people who said, I'm not ready to quit right now. Just smoke-free text is for people that have a quit date. We added content for people that don't. And we also added some messages to support nicotine replacement therapy, because I'll show you why in a minute. That was sort of part of the study design, is to add that element of support. And so what we did to adapt messages, we took smoke-free text messages, which anybody can actually download. They're available online. You can download this database. Actually, I think it's putting out text that we make available for download, but it's a bank of messages. And we went through and sent samples of those that we thought could be modified to better represent the source or local resources, or things that we were just not sure were fit for our primary care populations in these community health centers. And we sent people a batch of messages and we asked them to rate each one as they came in, to say, like, was this clear? Was this useful? And then we talked to them at the end of the day, after like 10 messages back and forth, about their ratings, about what would have made this better, what was good, what was missing. So it's this sort of model of, if I had to do it over again, I would do like a 5-star rating like we do on our ride shares. At this time, it was sort of a thumbs up, thumbs down. But we still nonetheless learned some great and useful stuff about how people reacted to those messages. And we intentionally did it this way instead of bringing them in for like a focus group to talk through the content, because it's a little bit artificial, right? Because you're supposed to get this messages when you're in the grocery store or taking your parent to the doctor or something. So what's your reaction when you see it, like when you're actually gonna get it in real environment? So we found, people were able to do this. They gave us the ratings. They were nearly all positive, which is why I think if the next time I do this, we'll have a slightly more granular scale so people can give us a 4 out of 5. We had embedded in there a bunch of links in smoke-free text so people know. Nobody clicked any of the links, so we could see. Nobody clicked links. And we could ask them why. And they said, well, I wasn't looking for the information. I didn't have time. I was at work. I didn't have internet access. Or like, I don't really use the computer. So we used that to basically strip out all the links. We added a couple back based on content that people told us in those interviews they thought we would send. Like they thought we would send information about vaping. So we added some resources expressing the uncertainty around vaping. And then we made sure that we included phone numbers for people instead of just URL links, to name a few things. Adapting this to put it into our local context led us to this very colorful slide. These are our messages sort of broken down by what each message was for. So the light blue is local resources, so messages where we put in information like that phone number you could call if you're part of this clinic and can use their tobacco treatment service. Some information about local coverage, like what the Medicaid benefit was, for example. The new stuff we added, I mentioned, was the not ready to quit stuff. That stuff really hadn't been in the text messaging program before this, and it's based on this idea of a practice quit attempt, which I'm going to tell you more about because I think it's kind of a cool and effective idea, and seemingly effective idea. So we had made a few messages that were encouraging people to build up their skills and their self-efficacy before they were ready to set a quit date. And we asked them to set a quit date. So just to add a little bit more to that, so that not ready to quit, that practice quit attempt, there've been a few variations of this. It's basically trying to, for people that aren't ready to set a quit attempt, how can you move them towards action, move them towards being ready to commit to a quit date? There's a couple of things that people do for this. One of them is the practice quit attempt, which I mentioned, which is an attempt to not smoke for a few hours or a day without pressure to permanently quit. So I can say, let's just see how long you can go. You can figure out what was hard, what the cravings feel like, what worked for them, what did not work. Starting to inform yourself and prepare yourself for when you're ready for a serious quit attempt where you're saying, I'm done, I'm not having any more. People sometimes combine this with nicotine sampling. So as you're going through, you're trying to see how long you can go without a cigarette, taking some NRT, ad lib use usually, to see how it helps you, where it misses, what else you might need. And there's just a relatively recent scoping review of the studies that have looked at this, and they found 8 RCTs that have looked at this sort of pre-commit to quit stuff, the practice quit attempts and the medications, and they found that 6 of the 8 were associated with increased cessation at 26, even though the goal of this is to get you ready to commit to a quit date. 6 of the 8 found an increase in cessation in 12 to 26, so they weren't all long-term versus a control condition. Yeah.
On average, how many attempts to quit do you think a person experiences before actually quitting?
And people have studied that, although the data is a little bit squishy because people's recollection of those and what constitutes a quit attempt is not entirely black and white. Usually we think of a quit attempt, by some definitions, we call a quit attempt at least 24 hours of intentionally not smoking. And the data is a little old. The one that I remember is over 7 times.
Okay.
But again, like there's a lot of caveats to that about like, I might be very serious at this quit attempt and I only made it 12 hours. And I just forgot that I just tried 3 times in a row because it all sort of blurs together about this one time that I tried to quit. So it's hard to measure.
I was curious too if there was usually like successive quit attempts or if there was some stuff too.
Yeah, usually. I mean, there's a lucky few who quit the first time they try, but it's single, like percentage wise, it's just like single digits. Although, and that's conventional cigarettes. So what people do to try to quit other forms of nicotine or multiple forms of tobacco, I don't think we know yet. Okay, so we took that adapted text messaging intervention and we did a pilot RCT, a 4-arm pilot RCT, where we wanted to compare We're gonna call our primary care patients who are listed as smokers in the EHR, as smoking in the EHR. We're gonna offer them participation in this trial, which will be randomized to either brief advice or brief by a trained research coordinator trained in a tobacco treatment specialist program. So she did brief advice where they got some NRT by mail, or they got the text messages, or they got both. And the idea was that we wanted to see if the text messages and NRT were additive in the same way that behavioral treatments and medication are in full longitudinal, fully powered trials. Because text messaging at this time at least hadn't been combined with medication that much. It was often sort of this general population outreach, or maybe a student or young adult outreach. But our idea was like, if you put it in the healthcare system and you can use it to make sure people know how to get these resources and that they have the support of their health system, and we get it to work together in the same way that some of our other things do. It was a pilot. It was powered based on quit attempts at 12 weeks. We only followed through 12 weeks. We had great retention of 153 people. 2 arms got the text messaging and people used it. Like, we were pretty pleased with this as a representation that our adaptation seemed promising, and that people stuck with the program for 2 months, which is a lot longer than they stick with it, at least based on the numbers for the public health texting programs, and they interacted with it. So they sent 17 and 20 messages back to the program. Some of those, most of those were prompted by queries. Occasionally people would just send stuff back to the program just because it made them feel good to talk to people. They sent emojis back and all kinds of things. Cessation outcomes are, we were powered to look at quit attempts, which we did not meet our primary outcome, largely because based on our power calculation, we didn't think that many people in the brief advice arm were going to make a quit attempts during that 12 weeks with just brief advice. So I think our nudge was a little more effective than we expected. About a fourth to a fifth of these people were not ready to quit at the time they enrolled, say, nope, I'm not ready to set a quit date in the next 30 days. We had I guess I should say, we had intentionally, we had some pre-specified subgroup analysis. In the overall group, our 7-day point prevalent abstinence looks about where you'd expect it for how effective we know things like NRT to be, which means in the arms that got a treatment, about 20, 23, 26, 28% quit versus 10% in the brief advice arm, which is pretty much on par for what you'd expect before doing this study. CO confirmation was really hard. This doesn't represent people who gave us a CO and then failed it. It represents people who would not come and meet us for the CO. So we had a solution for this, but it was particularly challenging. We were trying to go meet people when they had an appointment or get them to come into the center, and it was just really, really hard in this otherwise fully remote trial. We did do pre-specified subgroup analysis looking at the people who were ready to quit, so the people that have been shown to benefit from the texting. And there we did see some significant differences, both in quit attempts and 7-day point prevalent abstinence, but really no signal that putting the texting and the NRT worked better than either one of them. They all kind of seemed to work the same. I don't have it here, but we did some qualitative data on this to look at this in particular. For the people that got both, like, how did it go? What did it feel like? And some of the feedback we got was like, yeah, the texts were great, and the NRT, like the patches were good, but they didn't really go together. It didn't seem like they were the same thing. They were just these two things I was doing. So we're going to come back to that. So bear that in mind. So it looks like you could adapt things, meet people's needs, and it at least looks promising. So the other adaptation I'm going to talk about is a slightly different setting, also lowly sourced, but I put all those global stats in there to highlight we have all these treatments, but they're both underused domestically and globally. One population that's at particular risk for tobacco-related harms are people living with HIV. They smoke it 2 to 3 times the general population. And in modeling data, people with HIV who use tobacco lose more years of life to tobacco than HIV. This is a hugely impactful thing in terms of the health and well-being of that population. And we know that both the vast majority of people who use tobacco and the vast majority of people with HIV live in low and middle-income countries. So NCI funded some grants to study this, and we have one of them, and I'm going to tell you about how we have adapted that. So we're working with partners in India. India is home to 275 million tobacco users. We know from some of our preliminary work that people engaged in the healthcare system smoke at a high prevalence. 16% of adults in a Mumbai hospital that we did a survey with reported current tobacco use, and the pattern of use in the treatment gap doesn't look so different than it does in the US. So a little over half made it past their quit attempt in that hospitalized sample. They believed that quitting would improve their health. Many were asked about tobacco by a doctor, but very few used any evidence-based treatment, including counseling and medications. For the population of people living with HIV, we have a partner, we identified some partners in Chennai who run an HIV care and treatment site. And we had this idea to think about what can we do to identify an effective and implementable tobacco cessation treatment program in this setting, in Chennai, in this care and treatment setting. And what we decided to do was we were going to combine a behavioral treatment and a medication, because tobacco is so incredibly important that we wanted a comprehensive program. In populations of people with HIV, the only medication with placebo-controlled evidence of efficacy is varenicline. There have been studies of the others, but placebo-controlled trial that showed long-term cessation outcomes, varenicline is the only one that's done that. There have been additional studies of varenicline in this population. They haven't all universally shown an effect. The ones where it didn't, the teams have attributed it to adherence. The other thing that we have for people living with HIV is a behavioral treatment program called Positively Smoke-Free. This is not mine. This was developed by an HIV doc in the Bronx, Jonathan Shooter, along with some of his fantastic partners in behavioral health and health communications, like Larry Allen and Cassandra Stanton. And they developed this program in the US for delivery in person, by telephone, by group, and even a mobile health program. And they did long-term cessation studies. And so it is similar to varenicline, the one behavioral treatment for people living with HIV that has demonstrated long-term biochemically confirmed efficacy. So we said, we're going to take those two because we know they work. And we're going to adapt them to India. We're going to go with the mobile program here because they have 1 billion mobile prescribers and the cheapest data rates in the world. And it's therefore highly scalable. We did some pilot work to look at the prevalence of tobacco use in this particular population and found that 37.6% of patients reported current tobacco use in their care and treatment and clinical research site. About a third of people who smoke also used another form of tobacco, like smokeless. And then there are also smokeless tobacco use. So we proposed with this intervention in mind a 2-arm type 1 hybrid implementation effectiveness randomized trial, which meant we're really interested in showing that this can work in a comparative effectiveness study to a real world policy relevant control. But we also want to look and see what it took to put it into practice. Because that's, if it works and if it makes its way into guidelines or treatment guidelines, then having some information about how people can do this in other settings is really important for scale. So let's see, and I think I kind of said this. So start off with how did we get varenicline? What did we do to sort of set ourselves up to use varenicline in this setting? So I already said it's the most effective signal agent for cessation. The other thing in this setting where we knew that at least a third of the people who were smoking were also using a form of smokeless tobacco, varenicline is the only pharmacotherapy that has long-term cessation outcomes for smokeless tobacco. NRT should work, bupropion should work, but if you look at the Cochrane reviews, varenicline is the one that has the best evidence to show that it works. And so we thought if we're going to support people to quit all forms of tobacco, I think this is our best bet. We thought the timing was cool because Chantix was about to go off patent when we proposed this. Unbeknownst to us, it would also go out of production due to a contaminant. But so we thought this is cool because the first place it's going to be generic. It's going to be India, or at least one of those lists. So we thought we were quite clever. Turns out we stopped making Chantix and Pfizer, so that wasn't available in country. There were 2 generic manufacturers that popped up after that were in Canada and the US. Interestingly, one of them was manufactured in Chennai, but entirely exported to the US. So there was a while we were looking at getting this medication for our study that was exported to the US and then imported back into India. But luckily, there have been a couple of generic manufacturers that have popped up in the meantime, so that we have now found varenicline for roughly $1 a pill, which is a lot less than it is in the US, particularly right now with only 2 competing manufacturers. So one adaptation was finding this locally produced varenicline that was accessible. The second was because we're going to pair it with a mobile intervention, and we knew from some of these other studies that when it didn't work, we think it might have been adherence. We put some adherence messages in with our behavioral support. The behavioral sport is this positively smoke-free that was developed in the US in partnership with people living with HIV. And in addition to us thinking India is a really good place to do mobile health, we also, there's a little bit of data out there, at least one paper that talked about comparing different forms of behavioral support and the interests and preferences of people with HIV. And there is a little bit of evidence that a mobile health intervention might be preferable and might work better because it's just more appealing or accessible to people. The other thing is this intervention, because it is there's this suite of grants now, and this is the one behavioral intervention we have for this population. It's actually had been adapted and is being adapted in other settings in its in-person form. So we knew it was adaptable. We knew it had been used in a mobile setting in one place, and we thought India was the place to do it. So how did we adapt this program developed in the Bronx to Chennai? We started with a cultural adaptation model or framework. There are several of these out there. For people that are interested in this, there's a cool paper by Felipe Castro out of Arizona State, who compared a bunch of these cultural adaptation frameworks for interventions, and there's some common elements across many of them. This particular framework that had some of those common elements, we chose this one because I had seen it used to adapt a text messaging program for smoking cessation for English-speaking populations to Spanish-speaking populations in Kansas. So I knew it worked. It had worked for tobacco and across languages. So we chose this one, and it lays out the adaptation in 4 stages. Sources of information, accommodation practices, initial testing, and then your trial. Our trial is actually not an efficacy test, it's comparative effectiveness, but this is the figure from the study. And we did this over from March 2022 to July 2023 is when we finished this up. So I guess to go into a little bit more detail on what each of those stages was. So sources of information. First, we brought all of our experts on the team and our colleagues on the ground together and made some decisions about communication mode, content, things like that. First, the original version of this had SMS messages and a mobile web page that you accessed. WhatsApp is what's used in clinical care in Chennai. So we said SMS isn't the right solution, let's do it on WhatsApp. The videos, when the original Positively Smoke-Free mobile was developed, were 10 minutes long. I don't know if you guys can remember the last time you watched a 10-minute video. That is not the way people watch videos now. So we made the decision that these needed to be shorter to reflect the prevalence of short video media viewing. And then we looked through some of that pilot data that I told you a little bit about, where we learned about the prevalence of smokeless tobacco use and made sure that we included content to reflect smokeless tobacco cessation as well. And then we had also had some qualitative conversations with providers as part of that pilot study to ask them about how they address tobacco use in their setting. And so we learned things like when you ask how do you talk about tobacco with your patients, well, we talk about the effects on their health and the environment, which I thought was super cool because we definitely don't do that here. But sort of that as a driver of behavior change, that tobacco and tobacco products are bad for the environment, they're bad for you. So we worked some of that into the initial draft of messages and video scripts. We also at this stage brought in a UDX designer to help us put these pieces together from the perspective of the user. And we took those scripts and those message drafts to our colleagues on the ground, our local providers and counselors in this clinic, and had them review them. And they provided many suggestions to better fit it to the local setting. So we had something in there about drinking tea when you're having cravings. Tea stalls are a common place to smoke, so that was not the right thing to say. Instead, they had alternative suggestions for smoke-free places you could go if you needed a place to be smoke-free, like going to temple. They highlighted the fact that we didn't reference family enough, which is a huge driver of health behavior. So add more references to family. And the local team and our health communications partners, who are partners at the University of Michigan, actually developed the original mobile Positively Smoke-Free. They worked closely together to make sure they got the cultural references right. I think there's a reference to baseball in the original ones. We switched that, and to make sure that the vernacular was appropriate and correct. Yes.
I'm wondering, how did you select your patient population? Like, what kind of population were you looking for? Like the most affected group in a local context, or like just a distribution of the people in that setting?
Meaning, so why work with
like what are the demographic characteristics of your sample?
Okay, of this phase or the trial that we're.
I guess in general, like, what was your approach when you were going into a new, like, setting or context? Who were you trying to capture there?
So I think with the pilot data, we're trying to get a sense of what are the patterns and prevalence of tobacco use, who's using it, what products are they using? Because we know a bit about tobacco use among people with HIV in high income settings, but there's still a lot we're learning in low income settings, although what we are learning appears to look pretty similar, where people in low and middle income settings smoke or use tobacco at 2 to 3 times the rate of people of people without HIV. But I think the other thing was just sort of getting to know that there's a male predominance of tobacco use, particularly smoking. There's substantial smokeless tobacco use among women. There are a few women who smoke, and so we definitely have a male majority population. And then things like, and we had some pilot data that told us a little bit about ages and stuff like that, but it looked very similar to their overall population. And why I work with people with HIV, it had been a population I'd worked with before. There was a grant project announcement, and we know that it's they're a highly affected group and not getting enough treatment and support to address it.
Like, I was curious if eventually you were trying to tailor the types of interventions and text messages to specific subgroups.
More granularly?
Yeah, because
Not
I
yet.
think people respond differently depending on their age and gender.
Yeah, not yet. I actually have a comment on that later a little bit when we look at some different subgroups on the US population. I think that's right. And I think probably with the direction of technology, the tailoring and personalization is going to increase. But interestingly, with tobacco, even the sort of like very simple unidirectional untailored stuff works.
Yeah, that's interesting.
And so I think we wanted to do our best to take something that was evidence-based, make the needed adaptations to put that evidence-based thing appropriate for this cultural context, but not create a new intervention. I think tailoring and personalization probably would have shifted the intervention a bit more from what the evidence was from. Where this is sort of a hybrid implementation, this is a hybrid implementation effectiveness study. We didn't want to veer too far away from that, but I think that's probably the future.
Yeah, that makes sense. I was just curious.
Yeah, great question. So we had our after stage 2, we had our drafts, we translated everything into, there's 3 languages, the English version, the Tamil version, the Telugu version, which are the local languages. And then we shared that with patients in the clinic who spoke those 3 languages to get their perspective on what we built. And they added a batch of additional feedback. So things like adding messages to things like self care and medication. They had recommendations about how the videos looked, some of which we could respond to, some of which we were too far along in the production process. So we tried to do our best to manage people's expectations there. A couple of key things for study design they brought up was the videos talk about HIV. So they said, make sure that it is crystal clear in your consent process that there's a risk of HIV disclosure, and people should be mindful that you do some private if they are not disclosed. And then they also highlighted that there is a population we are leaving out here in this low and middle income setting, that is people who are not literate by using a text delivered intervention. So just to show you some pictures, I think I'm running out of time. Just to show you some pictures, this is what the original positively smoke-free looks like, and you can read more about it in the papers referenced, but it was developed in partnership with people in the US and delivered through this mobile platform. And these are some shots of how it looks in the adapted version. So the messages are delivered through WhatsApp. The video links are delivered through WhatsApp, and the video link is, the videos are recreated in these 3 languages, but the content is, the scripts are really basically adapted, but the content and the theory hasn't much changed. I don't want to spend too long on this. I just got out of the DNI conference, but just a nod to the implementation effectiveness study. And the implementation piece, it's a type 1 because we're really sort of doing an exploratory look at implementation. So mixed methods look at what it took to get this into practice. What are the barriers? What was the fit? How did we do with our adaptation? So this is the Proctor's implementation outcomes that we're going to explore a little bit with some interviews. And then I have 5 minutes. I want to talk about adaptive treatment models. It brings back a couple of things. So first, adaptive treatment is this idea that you start somebody on a treatment regimen and then you modify the treatment based on how they're doing. We do it all the time in hypertension, diabetes, depression management. We don't do it for tobacco, but there's a few studies that are starting to happen. One of which just came out this year, this really cool RCT where people were started on their choice of NRT or varenicline, and they were started before their quit date. Both of these have growing evidence that you can use them pre-quit. Varenicline's package even says you can start it up to a month before your quit date. And so you start that, and then 2 weeks in, you see people reduce their cigarettes. And if they did, great, keep going. If they didn't, you add on bupropion, like to bring in some of that data on combined medications. And they found the adaptive arm where they did that, they checked for response and they brought in bupropion, indeed worked better. They only did 12-week outcomes on this, but pretty interesting. But pharmacotherapy adaptation isn't the only way you can use these adaptive treatments. There's another kind of adaptive treatment called a step care model, where you start with something that's approachable, people are willing to do as a first step to make it, that first step, something that they can access. And then you escalate treatment for the people that need more. So we thought, hey, maybe we should try this with that text messaging program, but people said it didn't really go together. Let's start with the texting. People liked the texting in and of itself. And then for people that need more, which is going to be most people, then we add on NRT or some in-person coaching to give them more support. So we did a pilot study. A pilot smart I could talk about all day. It takes a long time to think through the ins and outs of what you're learning and how you're setting these up. So we thought we needed to do a pilot first. So we tested, we wanted to test when do you check and see how people are doing? Because we have no idea. It's 2 weeks the right time, it's 2 months the right time. How long do you need to work your way through something before you decide I need more, I'm ready for more? And then what do you offer? Do you need a live person involved here is part of the question. And that's based on this great study by Green and Prokhorov, who did a study where they recruited people from CBOs in Houston, and they offered them NRT or NRT plus SMS or NRT plus SMS plus a call from a person. And the call from the person is what mattered. That was the thing that made the difference over just NRT. So we're like, maybe we need a person. Adaptive interventions are complicated to think about because you have to make all these decisions and have all these, specify these components, like what's your decision stage? When do you make that assessment and change what you're doing? What are your treatment options? What are you going to tailor on? So at that decision stage, what is it that's going to tell you how they're doing? And then what are you going to do if they are or aren't improving or not? And so we set up this SMART trial. It's always so hard to look at. So we started out randomizing people to 2 different times to check on how they're doing, to that question of like, we did 4 or 8, maybe we should have done 2, that study wasn't out yet with the 2-week check-ins, we did 4 or 8. And then if you had quit at 4 weeks by self-report, we continued. Like, great, you're one of the lucky ones that did well with texting alone. If you didn't, you got randomized to either NRT by mail or NRT by mail plus a call from a coach. And same thing for the 8-week arm. And the way you set up the pilots are trying to see if you can send somebody through all these pathways, but not really being powered to look at any of the comparisons. So that's how we set this up. And we had a trial of 35 people where we tried to get people through each of the arm based on our estimate of how many responders we would have. People were retained really well. They generally felt good about the way these things fit together. And I just want to highlight a couple of experiences things to the point about tailoring. So generally, as opposed to the first version where we sent them both at the same time, people said, yeah, this is nice. The text messaging did a little something. I really think it was based on Cochrane's ratings of the potential for bias.
Okay.
So this is a good quality study and we really believe its findings, or like, there's a risk of bias. We don't believe it quite as much. So those are all pulled. That was a review of reviews, and most of the reviews have been Cochrane when it comes to tobacco.
Thank you.
So yeah.
Yeah, this was really great. And my concentration when I did my master's in public health was actually global health. So seeing it implemented in another setting, I think is really interesting. And kind of related to that, are there any plans or thoughts of implementing it in other settings? And kind of with that, I don't know what like the tobacco policies are in India or like other settings, and how might those local policies that might differ from what's in the US affect the implementation in different contexts?
Yeah, that's a great question, and probably a really long answer, but just to summarize, so we haven't done the trial for this yet, so
Okay.
first we gotta see it works.
Okay.
And we're gonna try and see how it went to get into practice, and we have a strong, we have a whole aim on cost effectiveness with it too, because I think that obviously is part of the picture for where you can do this. How much did it cost to deliver the intervention? We actually got a supplement, estimate how much it costs to adapt it to that whole one thing, those stages I just said. And the idea is like the hope is that it's replicable. It's like, get a little sense of your population prevalence, you talk with people on the ground, you show it to some patients, and this could be ready to go. So the idea is that it's replicable. We're going to put some costs on it just to see how replicable, and that probably will inform some ideas. I think the other thing on that front is the cool thing about this project is I get to be a part of a whole group of grantees who are working on tobacco cessation for people with HIV in a bunch of different countries. And so they're going to have a lot of information about what different interventions look like in different settings with different tobacco control policies.
Okay.
India has quite strong tobacco control
Okay.
policies. At least they have a lot of stuff on the books banning particularly harmful products and clean air laws and things like that. But they ban e-cigarettes altogether, so that's really nobody was asking me. I'm sure there's some use, but there's not as much use as we see here, for example.
Okay.
So I think it's definitely going to vary with the population. I think the big policy changer will be whether you can get into HIV care and treatment guidelines. Jamie?
I want to go back to the way in the beginning I made too much of a deal out of the fact that Coloradans were saying that they were not getting advice to quit.
Yeah.
And I was similarly a little bit shocked about it, but it's also consistent with the discussions we've been having with rural and urban primary care about lung cancer screening. And I'm wondering if the state's culture of being a healthy, on the healthier end of things, actually unmotivates and stigmatizes individuals with a smoking history to the meaning that, to the extent that they're less likely to get intervened upon for that.
Yeah, I don't know the answer. I was surprised when I say it. I will say the difference isn't like we're 15%.
No, it's not, but
it's like a bunch of people who
But
are
it's
within
2%,
5% from the
average.
median. Yeah, I know. Yeah, so there's work to be done there. I think it's interesting with Colorado's identity as a healthy state, whether that has negative effects because we all figure we're all pretty healthy anyways. But it'd be really interesting to look across some of the PBRNs to see what's going on with screening and documentation. Which is different than advice to quit, but even starting there. Yeah.
If no one else has a question, I'm gonna veer us into crazy waters. Having just left a CDPHE conference on psychedelics and its rollout in Colorado, and preliminary data is very supportive of very high quit rates. Is there any discussion or appetite, or could you see a place where there's some opportunity for a very pragmatic study here in Colorado as the Natural Medicine Act unfolds?
It seems like it would be the first place to do it. There was an SRNT session last year where they reviewed the evidence for psychedelics, all forms for tobacco, and the numbers are tiny, but the effect is enormous. So yeah, I mean, I think it seems like a place that has been successfully studying it in other settings. Seems like it would, I anticipate it would be easy to recruit for, because whenever I was recruiting for some of these studies, people would always ask me for studying. There's a real appetite for it. Yeah, with the funders that have an appetite for it, that I have less experience with. Yeah, it's cool, but the preliminary numbers are astounding. Yeah. Tiny, yeah.
I just have a very technical question. So I'm fascinated by this adaptive design, right? So what you showed us was kind of building this up, in the adaptive design. But then how is that implemented? And then how is that analyzed? I'm just curious if there's a kind of a short answer to that.
I think
because I understood what you did in terms of the development, right? And how you were, but then what do you do next?
Usually there's two phases. Often people think of the SMART designs as part of most, for people who know the most methodology and multi-phase optimization stuff. So first you figure out what your adaptive treatment is, like when you should ask, what you should tailor to, and then you compare that to what fixed treatment, right? Like what we usually do.
Okay,
So it's usually two phases.
okay,
And I think the first example I gave of that study where they added on bupropion to bradykinin, that was a fixed comparison, right? They said, okay, we're gonna do usual care, or we're gonna do this adaptive model, but they didn't vary. They varied the bupropion or not, but they didn't vary anything else. And that was, yeah, so there's sort of usually two stages, and then how do you implement it, I think is one of the real challenges, because it's not the way, it's like we
Don't think that
do
way.
it for other things,
Yeah.
so there's a way forward, but we don't do it for tobacco, so
Yeah.
you gotta have a way to assess response.
Yeah.
And I think digital health is probably a good way to do that, because it is something we can ask about by your phone or your health portal, say, how's it going, and then offer more functionally, but it's a different workflow than we're doing, so I do think it's an implementation question to get it into real practice.
But I also think those models emulate real practice a lot better than they do, because some of the stuff we do is strictly for us, as researchers or as clinicians, and doesn't really meet the needs of the patient or the individual where they are. And so making these adaptations and dealing with the methodological complexity is actually something that I think is very appealing.
Yeah, and I think there's two,
I agree.
I think there's two kind of interesting pieces, and I tried to highlight that. One is the idea is that can you hook people into something that they're willing to do as a first step, this step to care model. The other one is for people that really need to quit, like we should be this intense. We should start them off with a first line and add another one right away. And we don't, but we should, like lung screen patients, for example, or people with MI, like it's clear this level of density can work, at least from these early studies. Or not clear, it appears that this has the potential to work from these early studies, but we don't do it. So I think there's a need to be more aggressive there. And people are willing to try to quit, like, I love the adaptive design.
Yeah, do you think it's a money issue? I mean, everything you're saying is a little bit more intensive, right? Than just, couple texts or, whatever it is, the brief intervention, that sort of thing. So, yeah. You should do a cost benefit analysis as well when you get to the trial, because,
Yeah, I think it's always a money issue.
it's always a money issue.
Yeah, I think it drives the way we do so much stuff, whether it should or not.
Thank you.
Thank you.